I want you to think about a patient you had, an older patient, maybe in aged care, maybe on your ward, someone who's been there a few days. You actually know them. You've done their obs, they're not on your list of concerns. And then during your shift, something shifts. You can't explain it. You just feel it. It feels like they're not quite right, you know. And maybe they're a little more confused than yesterday. Maybe they're not finishing their meals, or maybe they just look off. Here's the part that stays with me as a clinician. Most sepsis patients don't look septic at the start, and that is exactly why they get missed. In Australia, sepsis causes thousands of deaths every year, and when you look at it, or when you look at the evidence, the most consistent factor is not delayed treatment, it's delayed recognition, which means this sits at the bedside, which means us. So today, I'm going to walk you through the three early signs of sepsis that nurses miss. Not because we don't care, not because we lack skills, but because these signs don't look like sepsis. Not yet. And before we start, I want you to sit with this. You could miss this tomorrow, not because you're careless, but because early sepsis doesn't announce itself. Let's start with what sepsis actually is, because if you ask tens or 10 nurses to define it, you would probably get 10 different answers, and that uncertainty is itself our clinical risk. The current international definition from sepsis defines sepsis as a life-threatening organ dysfunction caused by dysregulated response to infection. So let me put that into plain language. Sepsis is what happens when the body's response to infection stops protecting the patient and starts harming them. The immune system becomes uncontrolled, and instead of fighting infection, it begins damaging organs. And once that process progresses, it becomes much harder, yes, much harder to reverse. This definition comes from Mervyn Singer and the Sepsis 3 Task Force published in JAMA. It also marked a shift in how we think about sepsis. So, moving away from simple vital sign triggers and focusing more on organ dysfunction. That's the aim. Now, let's talk about what most of us were taught. You know, you may remember temperature above 38 or below 36, heart rate above 90, say respiratory rate above 20, suspected infection. That's the old source criteria, and many years that's been how we identified sepsis. But here's the problem. In real clinical practice, especially in older patients, sepsis often does not present like this, not early. And this is what we were taught actually see at the bedside. This gap is recognized by Australian Commission on Safety and Quality in Healthcare through the sepsis clinical care standards. The evidence is consistent. The biggest contributor to sepsis related harm is delayed recognition, and that importantly in older patients, in frail patient, in immunocompromised patient, the classic signs may be absent or subtle or delayed. Let me show you what this looks like in practice. Let's say Mrs. L. 82 years old, residential age care, history of type 2 diabetes, mild dementia, recent urinary tract infection. Her baseline, she's social, she eats well, she walks to the dining room with a frame. But Tuesday morning at 6 a.m., or 6 medication rounds, she's still in bed. She doesn't come out for breakfast. So the nurse checks on her. She's awake, not in pain. Observation, basically, temperature is 37.2, heart rate is 84, blood pressure is 118 over 72, documented as resident appears tired, obs stable, will monitor. By 1 p.m., heart rate becomes 104, systolic pressure is 96. She's now drowsy, confused. By 8 p.m., she's in an ambulance. So she had sepsis at 6 a.m. The first, and I would argue the most important, early signs of sepsis that nurses miss is a change in cognition. Not the obvious kind, not the patient pulling out, lines, not the one who is clearly delirious. I'm talking about subtle change. They're quieter than usual, less engaged. They answer your questions, but just a little slower. Their eyes follow you, but something feels different. In clinical terms, this is acute confusion or delirium, and in sepsis, this can be the first sign of deterioration. Before fever, before tachycardia, before abnormal obs. Evidence shows delirium can be present up to 30% of patients with sepsis at initial assessment. And in older patients, it may be only an early sign. It's also recognized in scoring system like QSOFA, where altered mental state is a marker of organ dysfunction. Now, here's the reality I want you to sit with. In patients with, let's say, dementia or a history of, sometimes being confused, these signs get labeled as baseline. And that is the trap. The question is not, is this patient confused or something like that? The question is this patient more confused than yesterday? The difference, even if it's subtle, it's a clinical finding. It must be documented, it must be assessed, it must be escalated. Under Australian Commission on Safety and Quality in Healthcare and NSQHS Standard 8, a change in mental state is a recognized trigger for clinical deterioration. This is not optional. If you see it, you act on it. So, what do you actually do? So, first is know the baseline. If you don't know what's normal, ask. Ask the family, ask the staff. Is this how they usually are? That question alone can change the entire clinical picture. Second is use a tool. The 4AT, which is a rapid delirium assessment, takes less than 2 minutes. It looks at alertness, orientation, attention, acute change. A score of 4 or more suggests delirium. Now, third, document precisely, not patient appears confused. Instead, patient oriented to person, not time or place, or slower to respond. Family states this is new, or 480 score is 4. Sepsis screening commence, something like that. That level of documentation protects your patient and it protects you. Now, Let's go back to Mrs. L. It's 6 a.m. She was quieter than usual. That was the first sign, right? But she had mild dementia. So that change, that change was interpreted as, as baseline. It wasn't documented as a deterioration. It wasn't escalated. Then 7 hours later, her family was driving to the hospital. One assessment, one note, one escalation at 6 a.m. The second sign is something you will see multiple times every single shift. A patient who is not eating, or say a patient who is not drinking, or a patient whose urine output has quietly dropped. And I know what you're thinking. That's half of my patients. Exactly. Because it's so common. Um, we've normalized it. We've made it as sort of like a background noise. And that and that normalization is where the risk sits. Let's slow this down and look at what's actually happening. In early sepsis, the body activates an inflammatory response, right? Chemical signals like cyto start affecting the brain, and the patient develops what we call sickness behavior, which includes loss of appetite, fatigue, withdrawal. This is not the patient's being difficult, this is physiology. Loss of appetite is an early signs of systemic inflammation. At the same time, circulation begins to change. Even subtle drops in perfusion affects the kidney. The body starts, conserving fluid, and urine output falls. So now you have less intake, less output. And both of those are early signs of physiological stress. But what do we do? We obviously chart, let's say, poor intake, refuse breakfast, pass small amount of urine, and then we move on. Now we're talking about communication, so this is what it sounds like at the bedside. Mr. K has a known UTI today. He has refused all meals. He has passed urine 200 meals in the last 8 hours. I'm concerned about early sepsis and would like a review. That sentence is the intervention, because what looks like a small change, is often the earliest warning you're going to get. The third sign is the one nurses feel the most and act on it, as or act on the least. It's that sense that something is not right. The patient is not in distress. Their observations are quite normal and borderline, but something has changed. The way they look, the way they respond, the way they carry themselves. And we say things like, "I- he's just not himself today," or she's a bit off, or something's not right. I want you to hear this clearly. That instinct is a clinical finding, and it belongs, in your documentation. Research consistently shows that nurses can identify deterioration before vital signs change. That gut feeling is linked to early physiological decline. And when nurses act on it, patients' outcome actually improves. Now, I know some people are uncomfortable with the idea of gut feeling. Because we're trained to rely on measurable data. But your instinct is not guesswork, it's pattern recognition. It's it's every patient you've assessed, every deterioration you've seen, your brain is processing skin color, temperature, eye contact, behavior, voice, posture, all at once is giving you a signal. Do not ignore that signal. Act on it. So what do you do when you feel this? You stop and you assess properly. Repeat observation, look at the skin, color, temperature, capillary refill, check hydration, mucous membrane, intake output. Ask K questions. When did they last eat? When did they last pass urine? Do they have known infection? Have they recently been on antibiotic? News to. A score of 5 or more or should trigger urgent reviews. But here's the key. Even if the score is lower, if you have a known infection, a change in cognition, and your clinical concern, that is enough, more than enough. Escalate. Now, when you escalate, this is what it sounds like. Calling about Mr. M. He has a known chest infection. Today, he is more confused than baseline. He has eaten nothing, and clinically, he doesn't look right. His news two is 4, and I'm concerned about early sepsis. I like him reviewed now. So it's clear, specific, clinical, confident. And if you meet resistance, well, if someone says, he's fine, just monitor, you document it. Concerns for early sepsis escalated. Medical team informed, plan to monitor and review. Because that note protect your patient and it protects you. Now, that feeling, something is not right, is often the earliest warning you will ever get. I want to step back from the bedside for a moment because this is not just a clinical story. This is also a system story. When sepsis is missed, we often hear the nurse should have picked it up earlier, and yes, that matters. That's why we're having this conversation, right? But here is the bigger truth: sepsis is missed in systems, not just by individual. If your organization does not have a clear sepsis screening protocol, if your documentation system does not prompt you when you chart confusion or reduce intake, if there is no clear escalation pathway linked to suspected sepsis, if nurses are not trained on how sepsis actually presents, then the nurse at the bedside is curing system risk alone. The Australian Commission on Safety and Quality in Healthcare, sepsis clinical care standard is explicit. Organizations must have systems to identify systems early and response within defined time frames. This is not optional, this is part of safe care. So, as a nurse, you need to know your system. What screening tool do you use? What triggers escalation? What does your sepsis pathway look like? And if you know, and if you don't know, ask. Ask before your next shift. because the nurse at the bedside, with their assessment, their documentation, their escalation, is the first layer of that system. And the system only works if you are supported to act. Now, let me bring this back to where we started. Mrs. L, 82 years old, recent infection. On that Tuesday morning, she was quiet. She didn't eat. She looked tired. None of those things on their own, sounds alarming. And that is the point. Sepsis is the early hour in the early hours is quiet. It is subtle. It does not always come with high fevers or crashing observation. Not in older patients, not in frail patients. So these are the three signs I want you to carry on your next shift. Sign number one is a change in cognition. Not are they confused, but are they more confused than yesterday? Sign number two is a change in intake or urine output, not just nutrition, but a sign of systemic stress. Sign number three is, yes, that feeling that something is not right. Trust it, assess it, document it, and escalate it. Your pattern recognition is a clinical tool. You will not always be you will not always be right. There will be times you escalate and nothing happens. And that's okay. That's the system working because a false alarm cost a review, but missed sepsis cost a life. The cost is not equal. And as nurses, we need to understand that. If if this help you, share it with a colleague, not for views, but because somewhere right now there is a nurse on the shift looking at the patient and not quite sure what they're seeing. And this might uh, what helps them to recognize it. So on next video, we're going to talk about failure to escalate, not as a nursing failure, but as a system failure. Um, what the evidence says and what your documentation needs to show when escalation is hard. So I'm Ed. This is Clinical Insights, and I'll see you next session.